Hi, welcome to case study 5. Hypothesis: the OCB restriction release through the craniosacral therapy techniques create more permanent resulting and lasting effect in resolving chronic sleep problems, difficulty breathing, headaches, neck and shoulder pain. The reason that this hypothesis was chosen is, first of all, to test the efficiency of osteopathy cranial techniques, and secondly, it is to help the friend of a therapist with his chronic health problems. It has been a struggle with his regular client in the last 3 years to find the right treatment plan and the right techniques that would promote a more permanent, lasting change on his health history. The client has given the therapist consent to be treated with an osteopathic approach. He's a 37-year-old male who has been having difficulty with his back, neck, and shoulders since he was a teenager. As an early teen, the client started to develop hyperlordosis, which was formed as an adaptive pattern to compensate the very unattended hyperkyphotic curve. This was due to quick growth spur and the desire not to stand out in front of the other peers. However, this did not affect the client's health up until he joined the military at around 28 years of age. After a few years with the training and serving abroad, the client has had one PTSD and some chronic tension in the upper back and neck region, resulting in a more chronic ongoing problem. Then he had a digestive tract problem, a stomach hernia, which was removed last year. Prior to that, he had no septum surgery as he started experiencing difficulty in breathing. And the last issue that arose was his irregular heartbeat, which was written off by the military doctor as nothing to worry about yet. In the past 2 years, after the onset of the somewhat chronic upper body issues, the therapist had tried using a massage therapist to help the patient. However, the recurrent symptoms would come back and again and again. Thus, the therapist does acknowledge the limitation of the current practice as a massage therapist and was eager to test a new modality for this client. The client's basic screening test reveals the following. The normal range of movements were found everywhere except for the trunk rotation, external shoulder rotation, limited thoracic spine extension. Physical observation via bowstring theory and fascial line palpation reveal restrictions in the front fascial line, lateral line, and the deep frontal lines, with the following structures affected: the scalenes, the SCM, the upper traps, temporal region, lateral, 7 to 10th ribs, hamstring, glute medius, hip flexors, inguinal ligaments, anterior compartment of tibial bone adductors. The lower cross syndrome is standing out judging from the lateral view. Moving on to the listening stations. The quality of 4 diagrams was poor in most stations except for the thighs and the dorsum of the feet. Rhythm has been very dull as it feels like the rate is longer in the feeling stage. Amplitude is even and symmetrical. The upper portion of the body, the lower rib cage, shoulders, and hyoid are holding tension, showing little movement into flexion. Partly the lack of quality movement in cranial rhythm indicates that we need to release these areas before going to release the OCB. Biological determinants. The client is showing multiple lesions as we have witnessed so far. First, most important to mention is a PTSD trauma resulting in psychosomatic lesion, aka stressful experience that took more than a year to recover, resulting later on in upper neck discomfort and dysfunctional sleeping pattern. Next up, the somato-psychological lesion, the alienation and tendency to isolate oneself from others, including loved ones, as a result of increased anxiety, lack of normal sleep, and increased irritation at work. And lastly, the somatovisceral lesion resulting in OCB compression of the cranial nerves, which culminated into digestive problem, the stomach ulcer, irregular heart pacing, difficulty breathing, and a chronic neck and shoulder discomfort. As we know, the OCB restrictions typically present with hypertonic traps, SCM, shoulder neck problems, digestion problems, breathing problems, headaches, all of which have to do with the compression of blood supply via jugular foramen, the glossopharyngeal cranial nerve 9, vagus cranial nerve 10, accessory cranial nerve 11. By releasing restrictions in the occipital base, the function of 9, 10, and 11 cranial nerves and blood flow can be greatly improved. And regarding the vagus nerve, what the therapist found interesting was that it has this particular function by stimulating the muscle in the heart, by helping to lower the resting heart rate. And it also stimulates the involuntary contraction of digestive tract. So some of the complications that can happen to the vagus nerve are the unusual heart rate and also the increased production of stomach acid. So that is worth mentioning as a side note, because that was part of the diagnosis for which the military doctor said that the heart rate was idiopathic and not as risky, but that was partly, I think, because of the vagus nerve compression. And then the hernia that was on the stomach had to do with increased acid, which is again attached to the vagus nerve compression. So back to our study. Things that may improve our clients' healing is more time spent for the recovery from the psychosomatic lesion, as well as a consistent attendance to the health centers, who can focus on psychological rehabilitation, osteopathic manual therapy, physio, chiro, naturopaths, endocrinologists, cardiologists, and even spiritual rehabilitation, psychological, to name a few. Time frame of the study. It's a 100-minute treatment wherein the first 10 minutes are spared for assessment. The next 40 minutes we focus on the client's fascial line restriction resolution. The last 40 minutes we went into the balancing of the diaphragm, the pelvic, respiratory, thoracic, and hyoid, followed by lumbosacral decompression, dural tube decompression from sacrum, the rocking and gliding of dural tube, and finally the occipital cranial base still point release. After all is done, the reassessment on the posture and the diaphragm square is performed to check the changes. Tools used: full body assessment via cranial rhythm, the fascial line assessment through the bowstring theory, and the postural observation or structural observation, and the 4 T's palpation. Lastly, reassessment of cranial rhythm. Results. There were considerable improvement in the neck and shoulder discomfort, judging by the release of trigger points, and a significant increase in the thoracic and cervical range of motion. Cervical range of motion improved by 20 to 30%, by the way. Increase in breathing capacity, disappeared headache, and improvement in sleeping pattern. The results have been obtained over the 3-week period, as the therapist needed time frame to see how the treatment affects the sleeping pattern and the chronic neck and shoulder discomfort. The still point achieved at the OCD and the dural tube rock and glide made a tremendous impact on the psychological and physiological release with the client. He felt like never before, as he put it. Also, the increase in space between C1, C2, and the occiput was felt, and the deep parasympathetic response kicked in, and put the client into mentally deep ease. The palpation of square was more defined and even in both filling and emptying stages throughout the diaphragm. Personal treatment plan. Client has approved the treatment plan as proposed by the therapist, satisfying the partnership principle of manual osteopathy. Due to intense work schedule of the client, we have agreed to meet once a month for the following 2 months, that is 3 sessions altogether. As for our immediate goals, the client has agreed to stay more attuned to his health issues, to maintain regular exercise, do diaphragmatic breathing, regular stretching of the neck shoulder muscles, and to attend closely to the physician if any physical issues appear. As for our following up sessions, the bone alignment issues will be addressed. We will closely target the next session, the Unity 1, 2 through osteoarticular adjustments. Unity 1, the anterior rotated pelvic coccyx alignment, pubic symphysis. Unity 2, we will work on the neck sway, C1 to C7 alignment, hyperkyphosis, cervical range of motion via MET techniques and fascia work. And of course, do the still point and the occipital release after having balanced the cranial diaphragms. Reassessment following thereafter. At the third session, we'll reassess again the unities and posture with screening tests and address the unity 3 if needed for specific adjustment. If not, then the therapist will once again assess score to figure out which diaphragm to balance out before treating the cranial bones. The dural tube traction from sacrum and dural tube rock and glide would be performed before the OCB release. Cranial bones assessment and treatment of the temporal and sphenobasilar compression decompression is to finish the treatment with vault hold and still point until a still point. The cost-benefit analysis shows that this is a win-win case because there has been a mutual business agreement arranged between the two parties and it's been satisfied. As for the therapist, this benefits him in a sense of gaining experience and practical utilization of a new approach in dealing with occipitally compressed patients holistically. As for the beneficent-maleficent principle, there is no harm predicted in the treatment offered, other than that of being careful with the possible psychologically triggered response of a client who has had a form of PTSD in the past, which can come up as an emotional trigger during the fascia work. But as evidence from the first treatment, there was no problem encountered. The therapist does acknowledge that there are limitations to the study. First of all, there is a time issue. Our client demonstrated a great deal of need of osteo, fascia, and cranial bone and diaphragmatic balancing during the first treatment. That takes a lot of time. The spinal dysfunctions of the hyperkyphotic and hyperlordotic curves could be more thoroughly addressed before the treatment by attending to the chiropractor place and getting detailed MRI for the chiro to help him adjust that. The study would benefit a lot more if a person didn't have to return to the high-stress job and be gone for a month at a time. And thirdly, we have a wide time gap between the treatments, making it difficult to get a lasting result through the infrequency of the treatments. Lastly, the sample size is very small. Of course, it was one person. Ideally, we would need to use at least 5 subjects with the similar conditions to see if the OCB release is working efficiently. Ideally, the short-term goal for our client is to maintain a healthy pelvic, respiratory, thoracic, inlet, and hyoid diaphragmatic balance through the regular attending of osteopathy therapist, manual therapist. Also, the properly prescribed postural exercises and stretches must be attended to on a daily basis in order to address the head-forward posture. The long-term goal of our patient is to address the overall well-being, addressing his other lesions listed above by referring him to the specialist and seeking a more balanced quality of life. Client could improve a lot by attending monthly chiropractic sessions as well as visiting the physiotherapist, psychologist, gastroenterologist, gastroenterologist, an acupuncturist, a neurologist, cardiologist to make a more holistic balance of the entire system. It is important to underline that osteopathy is playing culminative role in solving our clients' physical lesions through cranial work, as witnessed by an amazing results achieved in this study. However, it is also within the scope of practice of manual practitioner to seek an integral approach towards healing. And as mentioned before, other healthcare practitioners will be encouraged to participate, as it is a very important part in the philosophy of manual osteopathy. Conclusion. In this case study, the therapist has gained significant clinical knowledge of assessment, palpation, observation, and treatment skills. We have introduced and tested the osteopathic craniosacral techniques while incorporating osteoarticular and fascial remodeling techniques in the bouquet of treatment methods. Quite paradoxically, they all worked out to our best outcome when used together. The lesson is clear regarding the effectiveness of cranial OCB release techniques in regaining the mental resetting of sympathetic mode into parasympathetic one and allowing that space to be created for the cranial nerves 9, 10, and 11 not to be blocked, but in relaxing the wiring which stimulated so much trouble in the past. The client has admitted that his sleeping pattern is a lot better since the last treatment. Breathing is easier, hardly any headache, and that his neck and shoulders don't bother him as much. Therefore, we can safely conclude that the experience that has been gained here is surely valuable, and the therapist is gonna use it freely for our future clinical practice when addressing patients with similar ailments. Thank you.